everyone, welcome to this session of the pilot program from San Diego. I'm Luca Richeldi from the University of Southampton in the UK. I'm here with my colleagues Vincent Cottin, David Lederer, Sonye Danoff and Hal Collard. We just finished a very exciting ATS conference in San Diego here, and we are here to summarize for you the major findings of the session that we have been attending over the last 4 or 5 days. In particular, of course, we will be focusing on interstitial lung disease. We will be having a report from session on ILD but not pharmacological trials, and then a second report from a pharmacological trial, and then we'll have about half an hour to discuss altogether the results and the finding and what are the implications for this. Now, with this, I would like maybe to ask my colleagues that have been attending the ATS in these days, which would have been, in their opinion, the session that they attended that might have an interest for physicians interested in the management of patients with interstitial lung disease. Vincent, you want to start?
Yes, so I attended a very interesting session where I will mention 2 presentations. The first one was about detection of interstitial lung abnormalities in individuals related to patients with familial interstitial pneumonia. And this was presented by the group of Jim Lloyd in Nashville, Tennessee, University of Vanderbilt. And what they did was study 75 of these individuals related to a familial idiopathic fibrosis. And these individuals had a CT, they had the bronchoalveolar lavage, and some of them had transbronchial biopsies. And what they found is that in about 14% of these individuals who are, of course, completely asymptomatic, you can find subtle abnormalities on the chest CTs. In 14% also you find abnormalities on the transbronchial biopsies with some fibrosis. And overall you had more than 20% of these asymptomatic individuals who had either fibrosis on the transbronchial biopsies or some reticulation on the chest CT. So it shows that in families of pulmonary fibrosis you can detect some very probably early changes suggesting later progression to fibrosis. And in addition, in a third of the cohort of the 70 or 75 individuals, they could find TERT mutations in the blood, so there were carriers of these mutations, and they are currently trying to correlate the presence of mutations to the abnormalities on the chest CT or on the transbronchial biopsy, with the hope to be able to later predict which individuals in families will develop fibrosis. And this is very important because fibrosis will likely occur 10 to 15 years later, so it would be tremendously important to diagnose the disease earlier.
It sounds like a groundbreaking study to me. It's just highlighting the idea of the importance of genetics and the feasibility of early detection of this patient. Do you think, Vincent, just quickly, that these might translate outside from the family context to patient with sporadic IPF?
Well, it's not there yet, but the idea is to detect fibrosis earlier. So one of the ways to do it is really to improve our understanding of familial fibrosis, to better detect when fibrosis is familial, and then to be able to explain to these individuals in families how we can help detecting early disease.
So it seems like these data are supporting the fact that if you have a family with fibrosis, which is the definition that we use currently, is at least 3 cases in the same family, then to screen for the presence of interstitial lung abnormalities in the other family members is something that is worth doing.
That is what is suggested by this study. And importantly, the affected subjects do not have the same phenotype. Some of them can have typical IPF, and some others would have phenotype more likely to be an SIP or even organizing pneumonia.
David?
Yeah,
Your
so
news.
I wanted to build on that a little bit. For me, one of the really exciting things that were presented all relate to early disease. And we had 3 abstracts at the mini symposium on Tuesday. One was the one that Vincent mentioned with familial ILD from the Vanderbilt group, which I agree was really wonderful work. I wanted to build on that a little bit. They found interstitial lung abnormalities in 15% of those 75 family members, but they did transbronchial biopsies on almost all of them, and well over 15%, I can't remember if it was 30 or 40%, had fibrosis or other abnormalities on the biopsy. It was very interesting. And so kind of suggesting that there's a whole probably endophenotype that we're not able to detect with HRCT even in those high-risk patients. They also did some wonderful translational work and found short telomeres, not just in the peripheral blood mononuclear cells, but also in type 2 alveolar cells. They looked at telomere length, and it was shorter in those affected individuals. And they found evidence of some herpes viruses. I think there was EBV and CMV evidence in BAL and even immunostaining on those biopsies. So I think that work, and they also found MMP7 levels were higher and TIM2 levels were lower in serum. So that work in very early disease, they had a mean age, I think, of 50 in those unaffected family members. It's really exciting. And it parallels with the second abstract in that session, which was presented by, it was Ivan Rosas and Matt Hunninghocky's group, where they, as you all know, have looked at ILAs or interstitial lung abnormalities in the COPD gene cohort in the Framingham Heart Study, had these really exciting findings. What they presented in this abstract session was looking in lung cancer screening cohort from Pittsburgh and finding interstitial lung abnormalities and associating them with SYNDECAN2 levels in the blood and other biomarkers. So that work, I think, is critically important. We also presented an abstract, one of my fellows presented an abstract in the same session using quantitative method of looking at subclinical ILD, not yet completely validated, but we found strong links between the subclinical quantitative measure of interstitial lung disease in a population-based cohort of over 6,000 people between these subclinical changes and serum HDL levels, which was really interesting. And there's, as you know, a whole link between ILD and coronary disease and beginning to tease it out with serum lipids and also a link with ICAM1 levels. So I think these studies, which are all still very early studies, are exemplary in that they point us towards trying to identify that early disease. And clinically, when we talk about early disease, we're talking about people who have changes on CT or symptomatic usually, or on the verge of being symptomatic. But these studies are trying to identify it 10 years before. Think of all the new and interesting biological features we could identify as we go down that pathway.
That's quite interesting,
Yeah.
both in terms of pathogenesis and building up the concept of what is really early disease, right? And I think it's fascinating because you see it's the way forward to see patients when they have early disease. So we currently define patients that we enroll in clinical trial as mild to moderate, but these patients are really, they are completely asymptomatic.
That's right.
So that's
Subclinical.
subclinical.
Yeah.
Do you think that these studies will help both the understanding of the disease pathogenesis, but also to develop new tests, a new tool to find these patients earlier?
I do think so, and I think for me the primary reason to do these studies is not only to characterize what this is and what progression looks like over, in this case, probably 10 years or more, as these longitudinal studies have long-term follow-up now, but also to get at the biological processes that are occurring not in end-stage fibrosis, not in the last 3 years of life, but what are those early biological processes?
So in theory, this might help also drug development.
Absolutely.
Okay. So, Sonye, share your news.
So there were a lot of very exciting ones, but I think that I also was very struck by some of the studies that looked at new approaches to understanding the genetics of IPF, and particularly I was interested in a study from Japan that looked at a cohort of Japanese patients who had acute exacerbations of their IPF, and these patients were compared to a German cohort. the patients were characterized for a number of genes which have been associated with risk for IPF. And amongst that group of genes which were interrogated, there were found to be differences in the in a SNP associated with the TERT gene, which is the gene for telomerase, for the protein component of telomerase. And the risk allele was much more highly expressed in the Japanese population than it was in the German population. And I think that the reason that this is an interesting outcome is because while there's not a direct connection between this genetic mutation and the occurrence of acute exacerbations, there was a higher rate of acute exacerbations in the Japanese population than there was in the German population. The risk allele tracked with the patients who developed acute exacerbations. And it suggests that a biologically relevant gene may be associated not only with the presence of the disease, but with the presence of a very significant component that we associate with progression of the disease. So again, I think much like the sessions that each of my colleagues have mentioned, this is a very powerful first step towards thinking about patients in a much more refined way of phenotyping, and has implications potentially both for, obviously not something that can be applied right at the moment, but over the next several years hopefully will be explored further. It may have implications for identifying patients who are at higher risk of more rapid deterioration, and patients who might be more appropriate for further pharmacologic clinical trials, even at a prophylactic level, to try to prevent events which lead to progression of disease.
That's quite interesting. You think that these data may lead us to also differential management of these patients? So currently we tend to see or to follow up every IPF patient in the same way, within 3, 4 months, 6 months, it depends. But we don't really know. Some of them probably, they come to our clinics every 3 months for nothing. So you think these will help also to personalize not only the therapies, but also the way we take care of these patients?
Absolutely, and I think that those are the kinds of strategies that are necessary to allow especially diseases which are becoming more and more common, for physician care time to be focused on patients who have the highest risks, as a number of these studies have looked for, the highest risks of progression. And so much the same as biomarkers or identifying patients who have multiple family members, it would allow us to really focus in on a group who perhaps needs first earlier surveillance and closer follow-up.
Quite helpful. Thank you very much. So Dr. Kolla, I have to disclose the fact that Dr. Kolla spent most of the time of this conference on the beach. So I'm not sure he's going to have a good story, but maybe someone will tell you. No, do you have at least something?
Yes, you can learn a lot from the beach at this conference. No, thank you so much. Yeah, actually, I was going to exercise the co-chair's prerogative here and answer your question a little less specifically with actually a global comment that I think captures a lot of the spirit of these earlier discussions, which is that I think for me, this ATS particularly kind of heralds a new approach or way of looking at interstitial lung disease that I think we've been edging towards in the last few years. But I really saw it come out in full this time, which is kind of a natural progression of what's happened over decades of trying to move closer and closer to biology. You know, historically, back 50, 60 years ago, our approach to interstitial lung disease was very general. We didn't have a great way of classifying disease, and then we developed histopathologic and then radiographic or radiologic approaches to help us segment diseases into areas that had clinical relevance, but the underlying assumption there was that that was representing a unique biology. And I think what we're recognizing now, and what a number of, basically all of the discussions we just had and a number of other presentations at ATS exemplify, is that we now have new tools that let us really get truly at the biology of the disease, and we're realizing that although histopathology, radiology are very useful, they also have limitations, and we need to now figure out how to move beyond that into a different way of classifying disease. And that will hopefully directly lead to the issue you brought up, which is personalized or precision medicine. So that's very exciting to me. And as you mentioned, we'll see in some of the clinical trial results how that we may have some clues to that, or we may have some opportunities to look into that and explore that further. But so I saw ATS as this year as really a kind of coming of age of that approach and a challenge to the research community now to move forward with figuring out how to do that and make it relevant to the practicing clinician and the patients.
Thank you, Hal. A fantastic summary, and thank you to all of you for providing me and us with this overview of what we have been moving forward in the field of interstitial lung disease. I think that the take-home message, if there is any, stay tuned, because there is a lot of new things coming that can impact clinical practice. And we have big challenges in front of us that will need to be taken over, and I think that's very good news for our patients and for the colleagues that are taking care of these patients.